Thank you so much, Dr. Chan, for that informative and compelling talk. If any of you had any doubt about the importance of today's topic, I think Dr. Chan's talk dispelled any doubts you might have had. And I would now like to welcome Bill Dietz, who will give us the U.S. overview. Before coming to Washington University, Dr. Dietz served as the director of the Division of Nutrition, Physical Activity, and Obesity at the Centers for Disease Control and Prevention. A NAM member, Dr. Dietz has taken part in several committees and participated as an author on one of the Vital Directions papers. His many contributions to the field of obesity have been recognized by his receipt of awards, such as the John Stalker Award from the American School Food Service Association for his efforts to improve school lunches, the American Diabetes Association's Holy Rod Sherry Award for outstanding contributions to the field of children, adolescents, and the media, and the Nutrition Award from the American Academy of Pediatrics. It's my pleasure to welcome Dr. Dietz.
Good morning. It's a great pleasure to be here today, and I want to acknowledge and thank the organizing committee for this privilege. And this represents the second time this institution has focused on obesity. The first time was in the year 2000. And I think that it's apparent when one compares that program to the program today how much progress we're making. I'd like to leave you with four thoughts today. The first is, despite the ongoing increase in the prevalence of obesity in some groups in the U.S. population, I think there are clear signs of progress. Secondly, given the increase in severity across our population, we do not have the capacity to treat our way out of this epidemic and must focus on prevention. Third, young adulthood is a major and ignored period of risk for the development of obesity, and we need to move beyond our focus on children and prevent obesity in the 20 to 39-year-old age group. And finally, the consistency in increases of obesity across the U.S. population and across the globe for all age groups, for both genders and multiple ethnicities, points to a universal environmental exposure and excludes other causes like in utero epigenetic causes. So I'd like to begin by showing you a series of maps that we developed early on at the CDC based on the behavioral risk factor surveillance system. This system is an annual telephone survey of states and people within states, 150,000 people on average. And we made this series of maps to illustrate the spread of the epidemic. And you'll see in the bottom the key for prevalence across these states. Now, this is done annually, but I'm going to show you just 4-year increments. So this is 1994, 98, 2002, 2006, 2010. Diabetes follows these same trends, but at a lower prevalence. So this is diabetes in 1994, 98, 2002, 2006, 2010. The subsequent data from the BRFSS are not comparable because the sampling frame changed, but they continue to show this increase. And the costs of this are considerable, and the costs of diabetes alone are about $250 billion a year. So this is not only a problem that we can't treat our way out of, we can't spend our way out of it. One of the paradoxical findings, though, is that recently there's been a decrease in the incidence of diabetes. And this is paradoxical because, as I'll show you in a moment, the prevalence of obesity in adults, particularly in women, continue to increase. One would expect, therefore, that the prevalence of diabetes would continue to increase. One explanation for this, which I think you may hear more about later, is that we know that sugar drinks, soda, juices, have a direct impact, a direct effect on the prevalence of type 2 diabetes, and the consumption of those drinks has declined recently, which may explain why we're seeing the beginnings of a decrease in incidence. Now, when we focus more intensively on what's been happening over the last 15 years, we continue to see an increase in the prevalence of obesity among adults, particularly women. If one compares 2004 to 2014, the prevalence in men has been flat, and the prevalence in children, both boys and girls, has also been flat. And you can see here the current prevalence, the 17% of children and adolescents, 35% of men, 40% of women have obesity. And when one looks at the shifts in the median and the median is moving further to the right than the mean, suggesting there's increased skewing of obesity in the population. And in fact, that's what we're seeing. We're seeing an increase in severe obesity, such that 10% of women, 6% of men have severe obesity here. This is a body mass index greater than or equal to 40. And when we look at children and adolescents, 2 to 19-year-olds, we see the same thing. When we deconvolute these curves, it turns out that the greatest increases in severe obesity are occurring among the 12 to 19-year-old age group. And what this represents is a little bit uncertain. Are these individuals with a genetic predisposition to obesity, or do these represent an early exposure to adverse childhood experiences that are then expressing it themselves in severe adult obesity? Now, as I said, I don't think we can treat our way out of this problem. We calculated the number of adult physicians in the United States, family practitioners, general practitioners, internal medicine, OBGYN, and calculated the number of individuals with severe obesity represented either by a BMI greater than or equal to 35 or a BMI greater than or equal to 40. And the distribution of patients per provider is 164 of individuals with a BMI greater than or equal to 35, almost 90 with a BMI greater than 40. And among the pediatric practice side, there are about 50 youth per pediatrician or family practitioner. This is an enormous burden, and one for which we're ill-prepared. There is no standard of care, either for the adult patient or the pediatric patient, which again should focus us on the need for prevention of this disease, because we're not going to be able to treat our way out of it. Now, the ethnic distribution of obesity points up some really very concerning disparities. And in children and adolescents, we're seeing the precursors of what we see in adulthood. And you can see here on this curve that NHW are non-Hispanic whites, NHB are non-Hispanic blacks, and Hispanics are at the bottom. And the highest prevalence among boys, interestingly enough, is in the Hispanic population. Among girls, we see the highest prevalence in the Hispanic and African American populations. And this is more or less replicated in adulthood. The highest prevalence in adulthood is among African American women, followed in descending order by Hispanic women, and at the lowest level are Caucasian women. There are not really major significant differences in the ethnic distribution of obesity among men. And again, I think this speaks to the complexity of the disease and the underpinning contributors to it. Now, there's another legend, I think, that obesity, particularly in African Americans, is associated with poverty. And that, I believe, is an urban legend. So here I'm showing you the prevalence of obesity by socioeconomic status among men based on the poverty-income ratio. The highest prevalence of obesity in men by socioeconomic class is among non-Hispanic blacks and Mexican Americans in this slide. But among women, you see quite a different distribution. It is true that obesity is inversely related to socioeconomic class when you examine the entire population of women. But when you look at the specific ethnic distribution of obesity associated with poverty, it's only true for white women. And because white women are the majority of the population, when you look at all women, there does seem to be this inverse relationship. Again, the complexity of obesity by ethnicity is not an easy, there's no easy explanation. In fact, things like cultural acceptability of obesity may be a very important factor. Now, coming back to the successes, when we look at the changes in prevalence among 2 to 5-year-olds, and these are, I should have mentioned earlier, the National Health and Nutrition Examination data, we see a significant decrease beginning in 2005, 2006, reaching a nadir in 2011, 2012, and a modest increase, which is not statistically significant, in 2013, 2014. We are not yet seeing a decrease in the 6 to 11-year-old age group, although in that group, the prevalence is flat. And in contrast, among 12 to 19-year-olds, the prevalence is continuing to increase. Now, these data are buttressed by a variety of observations around the country, where we see 6 states and multiple municipalities that have observed decreases in the prevalence of childhood obesity. The sampling frames here were quite variable. The age groups were quite variable. And there's still work to be done to validate these findings, but for the most part, I think they're real, and certainly are consistent with what we're seeing in the nationally representative data. The important observation here, though, is when these interventions occur in mixed populations, white populations have the greatest benefit from these interventions, meaning that the disparities actually widen in response to these interventions, because white kids have decreases, but African American and Mexican American children have more modest decreases in prevalence. Now, I'd like to turn to a broader and longer view of the epidemic. And these the next several slides show changes in the prevalence of obesity among youth and adults. And the point that I want to make with these slides is that the changes from 1970 to the present are very consistent across the population. So these data show the curves in men and women and boys and girls. These are data that show the changes in the prevalence by age. Again, highly parallel curves. These data show the differences in adults by ethnicity. Comparable curves in children are much more variable because the sample sizes are lower, and they tend to be more confusing and not as consistent as we're seeing when we look at all children or all adults. Furthermore, when one looks at the global changes in the prevalence of obesity, we see much the same thing, not exactly parallel to the US data, but across age groups and countries, both developing and developed countries. The curves are parallel and quite consistent. And the importance of this observation is that it points to a common population-wide exposure, the nature of which is uncertain, but it certainly excludes in utero exposure to obesogens or endocrine disruptors. And I think that we now need to go back and look much more intensively at the kinds of changes that were occurring, and I'll show you those at least some of those in a few minutes. But I think that these population-wide changes were not just limited to the United States, but as these curves show, they were also true globally. The other insight that I think should prompt a rethinking of our preventive strategies is how we think about the 20 to 39-year-old age group. These are cross-sectional data. In 2 to 5-year-olds, the prevalence is 9%. In 6 to 11-year-olds, that prevalence is almost doubled to 17%. And then it takes another jump in the 20 to 39-year-old age group to 36%. If you look at the 12 to 19-year-olds, that curve is already beginning. But this age group of 20 to 39-year-olds is a key factor because these are people who are going to become parents. And so effective prevention of obesity in this group may have a spillover effect into the effective prevention of obesity in their children. The other concern is this. In the CARDIA study, which was a 10-year follow-up of a very substantial sample of individuals, The prevalence of excessive weight gain, 20 kilos or 44 pounds, occurred in 27% of African American women and 15% of African American men. Aside from that broad demographic observation, we know nothing about the association of these changes with broad transitions in adulthood, like leaving home or first job. My primary candidate, I think, for these changes is postpartum weight retention. But if we're going to be effective at preventing obesity and particularly addressing the disparities associated with obesity, the 20 to 39-year-old age group needs to be a focus. Now, what explains the shifts that we've seen? There is no single change in either on the physical activity side or the nutritional side which adequately accounts for the shifts in the prevalence of obesity that we're seeing in the U.S. population. These are data collected over a period of time looking at household management energy expenditure per week among women. And you may not be able to see these numbers, but in women who were not employed in the 1950s, or early 1960s, the amount of energy they were expending on a weekly basis was 6,000 calories a day. By 2010, that had decreased to 3,000 calories a day, about a 400 calorie a day increase. And that was obviously a consequence of a lot of labor-saving devices. And the only way for me to understand this was to interview my mother-in-law. And she was busy all day long. She made breakfast for her children. She then made their beds. She then cleaned the house. She then did the laundry. She had to hang it on the line because there wasn't a dryer. She washed the dishes because she didn't have a dishwasher. So this 400 calories a day of moderate physical activity was with housekeeping. And the decrease in employed women is also a decrease, but not quite as big, about 150 calories a day, which is also the kind of decrease you see on the part of men in the workforce. And I think that there are a variety of changes of physical activity, as I learned from my mother-in-law. One is increased use of appliances. For children and adolescents, physical education programs and recess have largely been eliminated from schools. Suburbanization, which has reduced walking and put people into cars, has also been a major contributing factor, and there are reasonable data now that suggests that car use is associated with obesity. And finally, we're in a post-industrial society where there's been a shift from manufacturing to a service economy and considerably less energy expenditure. There have also been massive changes in the food supply. This slide shows the amount of food that a family of four consumed in the course of a year in 1954. And you can see in the front, I think, that those rows are rows of milk. And behind those are potatoes. There are vegetables behind those, and above those there are meat, poultry, and on the left-hand side they're fruit. The only processed foods that families consistently used are in the upper left-hand corner. Those are cornflakes. Now, contrast that with what we're doing today. So today, there's an increased cost of healthful foods. There's a decreased cost of junk foods, which have driven an increase in the consumption of processed foods. Portion size, both in purchased products and in restaurant foods, has increased dramatically. And there's an increased variety. And the greater the variety of foods available to an individual, the more likely they are to overconsume. There's increased availability. Those foods are everywhere, in gas stations, convenience stores, supermarkets, and the number of products has grown dramatically. And over the same time period, although the Obama administration's Healthy Hunger-Free Kids Act has reversed much of this, there was increased school vending and a la carte foods. So how do we proceed? What do we think about in terms of prevention? Well, early on at the CDC, when we were confronted with this epidemic and were pushed to develop solutions, these were the first strategies we employed. breastfeeding, reductions in television time, increased fruit and vegetable intake, and increased physical activity. These were largely not evidence-based strategies. They were convenience strategies because there wasn't much of a research base to enable us to understand what was likely to be most effective. And over the last really 10, 15 years, the targets for obesity prevention and control have increased dramatically. I believe one of the most important strategies that we could adopt here today is a sensitivity to the stigma that accompanies obesity. And one of the easiest ways to begin to change that is to begin to use people-first language when we describe obesity. We will hear and have heard a description of obese people. Obese people, or an obese person, is an identity, not a disease. When we need to talk about people with obesity, to distinguish the person from the disease. We don't talk about cancer people, we don't talk about diabetes people, we do talk about obese people, and that I think perpetuates the blame that these individuals are responsible for their problem. To the reductions in energy intake, we've added sugar drinks, and I think you'll hear that this is a potentially very effective and important strategy. And pizza turns out to be one of the leading contributors to excess caloric intake in the pediatric population. On any given day, 1 in 5 teenagers has pizza. On that day, they consume almost 650 calories of pizza. They only compensate for 2/3 of that. So on that day, they consume an excess of 200 additional calories. Decreases in television time, which is what we know about, and potentially screen time is another important strategy that's a carryover from the earliest focus. Increases in daily physical activity is another essential strategy, and it's important to distinguish between physical activity for the prevention of obesity, where it's potentially effective, and physical activity for weight loss, where it is not. In individuals with obesity who become physically active, they change body composition. They increase lean tissue, they decrease body fat, but they don't lose weight. Their comorbidities certainly improve, but this is a very important and neglected largely strategy. There's been an increased focus on pregnancy, pre-pregnant weight gain during pregnancy, diabetes during pregnancy, and interestingly enough, tobacco use during pregnancy, all predisposed to early childhood obesity. Breastfeeding is retained on the list, and to this list, we've added sleep. So I'm looking forward to the rest of today. I think that what you will see is quite a different perspective for at least those of you who were here 16 years ago, when the focus was pretty intensively on therapy rather than prevention, and in an individual focus rather than a policy focus. But I think that I'm encouraged by the signs of progress that we're seeing in the U.S. population, particularly in our youngest children. And I think that we need, again, to focus heavily on prevention, addressing some of these targets that I've just provided you. And the novel approach that I'm proposing is to focus on the 20 to 39-year-olds, because I think that the weight control in that group will have a halo effect on weight in their children. And finally, I think we need to think much more seriously about the kinds of contributors to obesity, both within the United States that have operated across the population and across the globe. Thank you.